focus group data, and the survey data. So any questions before we move on to prioritization and implementation?
Yes, I have a question. This is
Sure.
Becca Trick. Sorry, I didn't relabel myself. Just in terms of the timing for publication of the report, we have historically referred to the Alliance report for more detailed methods. And so, in the CHNA reports, we'll say, here's the methods, but, check out the Alliance report on their website for more details, and we need to get ours up on our website by the end of June. So will yours be up at that point, or should we frame that a little bit differently?
No, it'll be up by the end of June. We're looking at a 20-day timeline for the design, so it'll 100% be up by the end of June. We definitely have the goal to have it up before the deadline for you all to have yours published.
Great, thank you.
No problem. Okay. So, um, today I'm just going to go through essentially how the MAP 2.0 process, which is, as you all know, is what our AHE process is based off of. Because our collaborative process is iterative and built on previous cycles, we modify the traditional model because we don't have to repeat things like creating a steering committee, forming work groups, things like that, because those are already in place. But I'm going to walk you all through the MAP 2.0 process and some of the tools that we've used to do prioritization and implementation planning. MAP 2.0 is what CDPH and CCDPH typically use. Most health departments use as their framework for their community health assessments and community health improvement plans, as well as the state. And it's also typically a framework that is employed by other entities that have to do CHNAs as well, such as ours, such as hospitals, FQHCs, for example. So it is a very thorough methodology and framework. What we've done is created a folder on the SharePoint for you all called Implementation Planning Resources. It's in the general folder of our SharePoint. And within it, you'll find a copy of the MAP 2.0 handbook. There are a lot of worksheets and fillable forms, and also a detailed it's a very thorough workbook that would also walk you through the processes that I'm going to be describing today. In addition to that handbook, we've created 3 folders with some example worksheets and downloads that you all can use or modify if you'd like. And it has links to where those worksheets come from. And those are in addition to what you'll find in the MAP 2.0 handbook. And of course, again, we often are asked to modify prioritization tools or implementation tools to help hospitals and health departments with their processes. So if you see something you like, but like assistance with us tailoring it to your needs, we're happy to help you out with that. But there's 3 different folders you'll see. They're organized sort of like by the point in the process, such as root cause analysis, implementation planning, and prioritization. So those are already up on the SharePoint for you all and ready to go if you'd like to take a look and use them. Also, again, check out if you want to look at the worksheets that MAP has available. They're in the PDF, so check that out as well. So within the MAP 2.0 process, essentially how it breaks down is that you create goals and guiding questions for your implementation and prioritization process. And then you'll look at the data from all of the different aspects of the assessment that we've done. So you'll look at the secondary public health data, you'll look at the survey results, you'll look at the focus group results, and you'll identify cross-cutting themes from the data. This is similar to what you'll find throughout our report and finally in the executive summary where we highlight like what the top issues that came out of the community input were. So you'll identify cross-cutting themes from the data. One example is mental health. And then you'll develop issue statements. So these issue statements, I'll give you examples, are basically stating, like it says, what the core health issue is that you are looking at in implementation. And you'll want to have an equity mindset. I'll give you an example in a minute, but it would be something like X% of African Americans have food insecurity in these neighborhoods due to these factors, for example. And then you'll do it has you do root cause analysis on the issue statements. Now, root cause analysis, we highly recommend doing some sort of root cause analysis process on the issues that you identify for your implementation planning, because it really helps you hone in on strategies that you can use to address the health issue that you have picked. And then you'll develop issue profiles, which is just sort of like a comprehensive summary of what the problem is, what the root causes are, and what the potential solutions are. And it's a really organized way for you to move forward with the work. So just to define terms and issue statements, again, is like a couple sentence statement. It summarizes why and how the issue occurs, how serious it is, and its outcomes and impacts. You'll see as we get into prioritization, a lot of the tools look at things like how prevalent is an issue, what would the consequence be if you don't address it. So this really helps you get to helps set you up for success when you go into implementation planning. So with the issue statement, you're looking at who is affected, how big is the issue, what contributes to the issue, and when and where the issue is most likely to occur. And then you would do a root cause analysis on that issue statement. And then after that root cause analysis, you'll be able to develop issue profiles, which include a description, what contributes to the problem, which is what you get from that root cause analysis, um, priority community indicators, looking at upstream and downstream metrics. So during the development of issue statements and issue profiles, you're also going to be identifying the metrics that you use to choose the issue, but also metrics that you could use to track your progress, as well as potential solutions, partner stakeholder assets to address the topics. Again, you get that from the data that we've collected over the course of this process. Does anyone have a question? Okay. All right. So within the MAP 2.0 handbook, this is a bit of it's a complex graphic. I put it in here just so that if you go into the MAP 2.0 handbook, you get to where this tracks to. Oh,
Yeah.
Lawanda, are you on? I think you're on speaker, unmuted, if you don't mind muting. So for the data triangulation process is what MAP 2.0 essentially calls the step-by-step process I just ran you through. So so CPA is like partner assessment. That's what that maps to. So that's like when we're talking about community asset resources, your capacity, your partner's capacity to address an issue. The community status assessment is actually what MAP 2.0 calls that secondary data collection. And then the community context assessment, the CCA, that's what was previously known as community themes and strengths, which is the focus group and survey data, so the community input. So we take all of that data, come up with general themes around the health concerns, the health issues, and what is driving those health issues, just some guiding questions or general themes. And then that's how you develop your issue statements. So here's an example of an issue statement. That's provided in the MAP handbook. It says develop, these are issue statements that are developed from cross-cutting themes. And make sure as you do this process, you maintain an equity focus. So one thing we know is that like there are so many needs and inequities that are identified through the CHNA. So your goal is really to look at the populations that not only you can have the most impact in, but those who have the highest, who are experiencing the highest inequities. So this is an example of a social determinant of health theme. So in the handbook, they actually divide the themes up into like categories like built environment, social determinants of health, health behaviors, for example. So the theme here is food security and food access. So in their partner assessment data, they found that food banks had close partnerships with neighborhood groups and have weekly food pantries. In the CSA data, which is that secondary data, they found that 75% of residents in these neighborhoods have limited access to stores with fresh fruits and vegetables, and 90% of African American residents also live in these neighborhoods. So you see that equity focus in the data there. And then when they looked at their primary data from communities, it said in all focus groups that were conducted in neighborhoods, residents noted that few grocery stores or places to buy groceries in our neighborhood have low quality fruits and vegetables. So they've triangulated the data to get a comprehensive look at what this issue is related to the theme of food security and food access. So you're going to take this statement and do a root cause analysis. So before I get on to this next phase of this process, do folks have any questions around what issue statements are or how they're developed, or any thoughts anyone has about how they've used this or similar techniques in their processes? All right, hearing no questions, I'm going to move forward. Okay, so root cause analysis, again, will be performed on the issue statements or just the health issues that you identify. There are multiple tools out there for root cause analysis. I'm going to show you the 3 most common tools that we have used as an organization. These are also tools that we've used with other hospital collaboratives and also with health departments, and as well and with other processes as well, such as like health action planning, or health equity in all policies work. So these are well-used types of tools I'll be showing you, but there are other options. Looking at existing models can assist with the process. So let's say you get your community advisory council or your group of internal stakeholders together. It's helpful to level set by reviewing existing models of like upstream root causes of health outcomes, because you all know we work in equity all the time, but that's not necessarily the framework that our hospital leadership, our health department partners, or even community-based partners necessarily look. So this is great for level setting. The Bar-High model, you guys have seen it, I'm sure, dozens and dozens of times. It's one of the models that both our main health departments use to guide their work. So looking at what are the upstream causes like social inequities, institutional inequities, and living conditions that lead to the health outcomes that we see in our secondary data, that lead to those issues like high infant mortality, high rates of diabetes, high rates of asthma among children. So setting that for that level as you go into root cause analysis again is typically helpful. Here's another one. This is one that is included, that we include in the CHNA report in our chapter about health equity, looking at how things like structural and systemic inequities like xenophobia, racism, ableism, transphobia have impacts on everything from social capital to employment, and how that impacts social influencers and determinants of health, such as health behaviors, public safety, housing, and that all, of course, impacts our health outcomes. So this is a example of a filled out tool of the tree diagram. Y'all might have seen this before. I know y'all are seasoned public health folks and hospital folks, so you've probably seen this before. There is a similar diagram that CDPH used in their last Healthy Chicago plan that outlines their process for addressing health outcomes. It's just generally called a tree diagram, but this one is also one that can also be a tool that you use to like lead these discussions with partners. It's really simple to do. What we typically do is we'll put a flip chart at the front of a room with a tree with the roots and the trunk and the branches and leaves on it. And then we work through this process with folks. We said, we say, what did you see out of the data? The CHNA data, we usually give like a quick overview presentation of the CHNA data. These are hopefully people that y'all have been meeting with regularly throughout the process. We highlight we talk about like what did we see as those leaves, like what are those key health issues that are popping out. So diabetes, heart disease, obesity, cancer, injury, depression, those are all ones I know that you all have focused on in the past in your implementation plans. And then you look at what are those contributing factors, the social determinants of health, which become the tree trunk. So you ask folks like, for example, when it comes to behavioral problems, what are the factors that contribute, or sorry, like depression, where are the factors that contribute to it? And where are the social determinants of health that are leading to those health outcomes? And then looking at the structural root causes, like what are the cultural and underlying systemic issues that are causing these differences in the social determinants of health or access to the social influencers of health. So that's how you would work through the process. It's really simple visual process that you can do with folks to get them thinking about root causes, but this is also a way that you can demonstrate your findings of the process is this tree diagram. It's one that, again, CDPH has used. Another one is the fishbone diagram. So those of you who specialize in program management would be familiar with this or who have done this work before. This is an example pulled from the NACCHO MAP 2.0 handbook. So in here, they look at, you essentially highlight the top. So you put your issue statement here, and then you highlight what you know are sort of like those core, this would be like the trunk, like these core issues up here, or core, sorry, not core issues, core influencers. And then you look at the data and look at why this is happening. So for example, we know that neighborhood is a core influencer of people's ability to access food based on the data. So what does the data say about how neighborhood is influencing this issue? The data says that there are very few grocery stores in the neighborhood, community gardens are not sustained in the neighborhoods, and that is contributing to this outcome. Those are, examples of the root causes. And these are also, as you notice, issues that could be intervened upon essentially. So you have an intervention point here. But we'll go to the 5 whys diagram. This one, the fishbone diagram, although it does provide a good basis for identifying root causes, it's not necessarily a process that gets you down to like a singular root cause or like a few root causes the way a 5 whys process would. So people often pair the fishbone diagram exercise with the 5 whys, which we'll get into next, but this can also work on its own. You'll just want to really facilitate the process to get folks to be very comprehensive in how they're understanding root causes. For example, like state SNAP agencies do not have good representation for residents in these neighborhoods. Limited economic opportunity, large corporate decisions. So you'll be comprehensive, and it'll also start to give you points of intervention for your implementation planning. So on the shared point, there are a couple of different fishbone diagrams that you can use in addition to the one that's in the handbook. There's one that has these they're all editable. There's one where we have edited to include these to get you all started to get an idea of where everything goes. There's also a blank one, and we've kept the citations and links into where those diagrams come from. And there are some and they do include explanations on how to fill them out. So those are available on the SharePoint for you. So this is the 5 whys. Now, the nice thing about this process is it really does focus on getting you down to the base cause of an issue. So this is an example of a filled out 5 whys worksheet. There, again, you can get it all out of the handbook. There's also printable templates in Word that we've created for you all that you can use for any sort of meetings that goes through the process. We have a couple from other sources that describe the process, and then just a couple of blank templates for y'all that you can use. And again, this worksheet's available in the handbook. So you essentially, they found through, I guess, research, because this seems to be the universal consensus, that if you take people through a process where you ask them why about an issue 5 times within 3 to 5 iterations of that process, you will find the root cause of an issue. So typically, again, 3 to 5, this gets you to the bottom line sort of intervention point. So, oops. All right. So, what you would do is, so you have your issue statement. 75% of residents in this neighborhood have limited access to quality grocery stores with fresh fruits and vegetables. So you would ask why. The first response is there's a limited number of quality grocery stores with fresh fruits and vegetables. And then you could ask the question, if we were to fix that problem, if we were to make sure that there were plenty of quality grocery stores with fresh fruits and vegetables located in these neighborhoods, would that issue be solved? If the answer is no, you ask yourself why. And then you say grocery store corporations and small businesses with quality fresh foods do not receive tax incentives to set up stores in these neighborhoods. If you were to fix the tax incentive issue, would it solve the problem? If the answer is no, you keep going. The city does not have any policies that promote investments in these neighborhoods. If it did, would it solve the problem? No, you keep going. So you keep going until you get essentially to a point where it doesn't make sense to ask no or to ask that question again. So at the end of the day, neighborhoods have mostly attracted minority low-income renters due to their affordability compared to other neighborhoods in the city. If we were to address that issue or ask why that issue is occurring, is there anything else that we could add to that that would enhance our understanding or be an underlying root cause of that we haven't already identified? If the answer is no, you've gotten to your root causes. And in most of the worksheets, you'll see you'll have a few root causes outlined. So this gets us a very comprehensive set of interventions, as you can see. So, and it also has us thinking about the level of intervention we want to act on, right? So we can, work on policy to maybe create tax incentives for businesses to provide fresh fruits and vegetables in a neighborhood. That might be a more upstream approach compared to just increasing or an upstream approach to increasing access to fruits and vegetables. So this process, again, similar to the fishbone diagram, helps you identify potential intervention points based on the data, as well as identifying root causes and upstream approaches. So are there any questions about root cause analysis before I move on? Okay. So in terms of issue profiles, this is essentially just a summary of everything. So you're going to create a description of the issue, contributors to the problem, which you would have identified in a root cause analysis, a set of priority community indicators, which you would have looked at in the process of identifying the issue, and you'll also potentially are identifying as you do like root causes. And then you look at potential solutions, including partner stakeholder assets to address the topic. So this is an example of like sort of a table that the map process uses to sort of outline that data. This is not like a set way of presenting it, just an example. Obviously, I've seen people present this a few different ways, but if you look at something like food security, the metric percent of households experiencing food insecurity, which would be what you could potentially use to track your implementation progress. And then here's the summary of the data or the themes. So this is your justification essentially for identifying food security and the metric that you would use to track it. I know that some of these metrics are big, they're big. So acknowledging that like percent of households experiencing food insecurity, because we're talking about such a large population in Cook County, is not going to be the only metric that, for example, you all would use within your individual work to track it. This is an outcome metric. Sorry, long-term outcome metric. All right, so I'm going to go into phase 3. I put this here so y'all can review. It's essentially like everything that we just talked about is in phase 2 of the MAP process. And then phase 3 is where they get into the implementation planning. We won't go as in depth into this section because we want to have time for discussion and you all can take a look at it. But it breaks down into, now that you have your issues, the goal is, as you all know, to identify strategic or to identify strategies to improve the health of communities that you serve. So the prioritization methods, so like this can be used at a couple different points. So you can use prioritization techniques to identify your health priorities that you want to address. So this would be in the process of developing essentially like issue statements, like looking at all the data, where do we need to prioritize our work? Because, there's probably something like 100 different there's over 150 different indicators in our report, and that probably is across 50 different health issues. So how do you prioritize health issues when working with your community partners and internally within your health systems and hospitals? This can be used to do that. This can also be used to prioritize strategies. So you can use it in both phases of your process, or one or the other. We've seen it done both ways. There are several different methods. The MAP handbook actually does a good job of sort of describing what they are. I'm going to give you some real life examples in a second. The ones we use most often, IPHI that we have typically used most often is the multi-voting. This can be really low tech. One way we do this is we put a health issue that folks have identified onto a flip chart, and then everybody's given 3 sticky dots, and they're asked to go vote on what they think their top 3 issues are, or what the top 3 issues should be for their hospital to address in their implementation plan. And we look at how many votes each one gets. And you can multiple vote. Some people will go up to opioid use disorder and put all 3 votes there. So that's an example of like really low tech, really straightforward. It forces people to prioritize health issues. The second one we use quite often is the prioritization matrix. And that's when these are really good for when you're restricted. So you all typically choose 3 to 5 health priorities that you want to address in your implementation plans. And you typically have a lot of criteria around that, right? Like it needs to be financially feasible. You need to have the internal capacity. You need to look at if you can have a significant outcome, if the intervention would be socially acceptable for the community. So in this, I also provide a bunch of different examples of prioritization criteria we've used, but the matrix is essentially having people look at those different criteria and rank where a health issue falls on that matrix. The strategy grid is a similar tool, but again, it focuses on like it primarily focuses on that thing like feasibility and impact. So instead of you look at a few different criteria, but instead of having like this whole list of prioritization criteria, you essentially have them look at like what's the most impact versus most, or sorry, your axes on the grid are feasibility and impact. So looking at um, what's high impact, what's highly feasible is typically where you'd want to center your work. There are a couple of other techniques that are much more complex, but they can be helpful. The Hanlon method is the one that I personally have, in 11-ish years of doing this, have not used personally, have seen it used as a much more like statistically complex method. And the nominal group technique is great if you want to just get a list of brainstorming ideas. So this would be more commonly something that we would do with like a community partner or community advisory council. And then we would take that information back to a core group within a hospital or health system. And then within that core group, further prioritize the issues. All right, so here's examples of different tools. So here are those flip charts I told you about. An example from a meeting that we did where we literally wrote out what folks were telling us during the meeting as we went through the data that that the group had identified as top issues, and we had them go vote. We rewrote the flip charts during the break so that we had the core issues like mental health, substance use. For example, we would put reaching undocumented populations and screening for mental health and chronic conditions, and we had folks go up and vote. This was the results. The spreadsheet shows they were given 5 dots for voting, and these are the results of that voting process. Here's another one that we've used. This template is available in the SharePoint. This is one that we used with Loyola back in 2022, where they had identified, they had internally gone through and identified sort of the key health issues that popped out from the CHNA, and then they had folks choose 3 topics that should be prioritized, and then had them comment underneath the subpopulations or subtopics within these major categories that they think should be the focus. And then we summarize that data. Another tool that we've used is Padlet. Here's an example of one that Sam did with our mental health work group, where we went through a process where we put up the major issues that were coming out for people and sort of additional subpopulations and priority areas to focus on. So example is like fostering collaboration. Educating social workers about coordination of care and getting more resources to help with the coordination of care is an example of a strategy that was identified. And again, this is using the Padlet tool. It's a free tool that you can use online. We use it a lot in these sort of virtual processes. So if you want a tutorial or assistance in setting one up, we can definitely do that for you. And then here's these examples of prioritization criteria that I told you about. There's also several listed in the MAP handbook. These are similar to the ones in that handbook, and these are modified. And you'll notice these are similar to the prioritization criteria that we used in our last CHNA process. So relevance of the issue to community issues, urgency, trending health concerns. So thinking about forces of change during our last round, COVID-19 obviously was the big one. Opportunity to apply upstream approaches, cumulative impact. So looking at what the long-term cumulative and historical context of the issue has been and alignment with other efforts. So looking at prioritization criteria would be something that you would use with this type of Padlet setup or these community health priorities. You would give them a list of criteria to look at. This is an example of the strategy grid where you see high feasibility or feasibility on one axis, need on the other axis, and you have folks sort of group issues. And this is an example of the output from that type of process that we've had. All right. And then finally, I won't go through this as an example of how we've done it in the past with the AHE steering committee and groups, but you'll want to try to reach consensus on it. So remember, consensus means not everybody may agree with the exact outcome, but they can live with it. So fist to five voting is a popular one that's used by both us and the health departments. There are other consensus building activities that you can use. So this to make sure that you may have a partner who's like, my specific food strategy was not picked, but I could live with the food strategy we went with, or I could live with addressing this other issue. Consensus, obviously, as you all know, is good for maintaining and the partnerships and getting folks to work together, and also, again, further prioritizes the issues for you. Real quick, here's an example of what that looked like. This is something that I've presented to other collaborative processes in other states of how we take the data to the action. So this example from our last CHNA, we saw both survey data and secondary data really highlighting that access to fruits and vegetables are important. So we work to support and form a work group around food is medicine, expanding food is medicine and Veggie RX programs. Some examples of this is not the exact, these are not this is separate, but these are examples of outcome metrics that you could use for a program like this. Changes in fruit and vegetable intake, food insecurity rates, self-reported health status, A1C, blood pressure, and BMI. So you see it's a mix of long-term outcome metrics as well as metrics that you could measure on an individual level to track progress of your program. So that's an example of how AHE in particular has taken data, AHE partners have taken data and turned them into specific programs to address health, and examples of metrics that you could use to track your progress. All right. So we have about 10 minutes, 10, 15 minutes left for discussion. So we wanted to open it up to you all. If you have any questions about what I've just presented or so we really want to hear from you all though about what techniques your organization has utilized to prioritize health issues and develop implementation strategies. So we want to hear from you all like what techniques you've used, and we want to open it up for folks to ask each other questions about their processes. So feel free to come off mute or use the chat. We just want to hear from you all about what these processes look like for you, or if you have questions.
Hey, good morning, everybody. This is Dolores from Cook County Department of Public Health. I do have a question. I'm trying to formulate it, but I feel like we've kind of done things, and I know this is not a linear process, but we have voted on our top like 5 bigger like health priority buckets right now. And so now we're trying to go back to work on the issue statements and the issue profiles. And I'm kind of getting hung up on what that looks like, how we drill down from that, and how to lead this internal group on drilling down to that. So, for example, one will be chronic disease. And so, that's a huge priority area. So, how do we drill down to issue statements and profiles? And would it just be one issue statement, one issue profile for that particular bucket?
Does anyone have thoughts? I want to see if the group has any thoughts, and then I can chime in with what I know of the process. Okay. So, and thanks for that question, Dolores, because it's an important question. So when you look at how NACHO does it and MAP 2.0, you do end up with multiple issue statements. You often end up with multiple issue statements per topic. So this example was like African Americans, food insecurity in a particular neighborhood. You might have a different issue statement that is related to I guess it's not exactly food security, but an example would be like diabetes rates are high in this neighborhood, is the issue statement among Hispanic Latino community members. And then your root causes would then be food security. So it's like, it's not, the goal isn't necessarily to come up with a singular issue statement or issue profile. You might have multiple, and that's sort of outlined in the MAP 2.0 handbook. But one thing that might be helpful for your process is to think about going through like a root cause analysis or a further prioritization process to look at what the core issues are, which is what you would get at through the root cause analysis. And that might help narrow down what strategies you need to focus on. The other thing you could do is further do a prioritization process to say, we've done a, like, for example, we've done a fishbone diagram. These are all the areas in which we're seeing that we could address this issue. Let's prioritize based on what we've identified here. So there are a couple of ways that you could go through it. Those are just examples of what I've seen described in the MAP handbook. It's also what I've seen a couple of different health departments outside of Cook County do. But yeah, it's not restricted to one. And I know it's not like there's a definitive answer, right? Of like, you want this many for food insecurity, for example. But again, using a root cause analysis or looking at a further prioritization technique might help narrow it down a bit for you. I hope that's helpful.
Yes, somewhat. And I think it's also going to be a matter of doing and trying it out and kind of stumbling through it a little bit. But that does help. Thank you.
Yeah, and one thing that we end up having to emphasize a lot when when we facilitate these processes is that consensus piece, right? Because it's like it's hard to take these issues that we know a lot of times feel they are equally important, but understanding that choices have to be made at the end of the day about what we're going to address and trying to reach consensus and reminding folks that it's what you can live with and agree is the best course of action for the whole. Even if it's not necessarily what individually or our individual department would have chosen to highlight, it's something we can live with. So what else? What other questions or thoughts do folks have?
This is Leslie from South Shore Hospital. How are you doing?
Good, Leslie. Thanks for joining.
Okay, thank you. Maybe I'm a little slow sometimes. It seems that the process that we're describing, utilizing 2.0 and going through some of the root cause analysis and those processes, are a little different than what we did in the past to get to the end goal for our CHNA. Am I correct or incorrect on that?
No, so you're correct, Leslie. So there are a couple of things happening here. So we do not use the strict MAP 2.0 process for the AHE. I use it as we use a modified version of it. So we don't do everything by the book, but the MAP 2.0 process is brand new. So it was released in 2023. And previously we had used MAP 1.0, and although a lot of the core components are the same, the way this process works is fundamentally different from how it's been done in the past. So for the most part, folks are just now doing their first, like across the nation, people are just now completing since 2023 their first assessments using this framework. So it is a newer framework, and that's the other reason why it's a bit different from how we've done it in the past.
Okay. I just, yeah, because I had not recalled us spending time like this in how we were getting to the end. And I hate using that term, but that's how I think is getting through the process, getting to the end to get to what we're going to post and try to improve on. And so I just wanted to make sure that I wasn't asleep for years. Okay.
No, and I know that when I present this, because how do I put this? The MAT 2.0 handbook is pedantic in a way, so it is very detailed, and it really goes into the underlying reasoning and the underlying sort of methodology, pedagogy behind what their framework and their model. So they go into great detail. And so when explaining it to folks, when going through it with folks, it seems very complex and very complicated. And although these processes can be difficult, they're not to come up with final decisions. They're not difficult to implement. So we've done prioritization processes with you all many times. We've done root cause analysis with you all many times. They can be done over the course of a single meeting or 2 meetings. These are not necessarily, like, these are not things that take months to do. Unless you wanted to. But for the most part, most people are able to get this done in 1 or 2 meetings. We typically recommend 2 meetings to go through all of this. So it seems complex because we're going under, like, because you all would probably be the people that would be facilitating these conversations or working with us to facilitate. So I went in depth. But again, these are not, when you get down to it, not overly difficult processes to implement. Any other thoughts or questions? All right. I appreciate you all joining today. Unfortunately, we weren't able to work out a guest speaker from one of the hospitals. They weren't available for the meeting today, even though we switched the meeting time to try and see if that would help with availability. But what we'll do is we'll reach out again to a couple of folks before our next meeting in June. And we'll either ask them if it's all right if we upload a couple examples of like their implementation spreadsheets so y'all can see a real life example of how one or two of your hospital partners are doing it. Or we could have them come on and talk for a bit during our next meeting to give you guys an idea of how this process is working in real life for folks. Um, so in addition to that, we'll be, and we can, because we didn't get a chance to go into it during this meeting, but it's that time again where y'all are finalizing your reports. So we're going to start collecting implementation information from all of you around what priorities you choose and what implementation strategies you choose. Y'all are on different timelines for this, we know, so this is going to be an ongoing process throughout the year, but we want to start gathering that information, and we want to know from y'all what format y'all would like would be most helpful for y'all to see that information in. And as typical, as you all post your reports online, we will be linking them to the AHE website. as soon as the final designed report gets posted, we'll let you all know. It will be done before June 30th. I 100% guarantee it will be done before June 30th. We'll let you know when it goes live, in case you have links within your individual reports for it. We'll also be sending updates like we typically do through email. Please reach out ASAP with any TA needs. We know we're coming up on the June 30th deadline for a lot of you, and we want to make sure there's enough time for us to get you any remaining assistance you need on your reports. So please reach out to both myself and Sam about any needs that have popped up. The more time you give us to help you, the better we can. So we appreciate you all, and enjoy the rest of this fantastic day.